Hello. Hello.
Yes, ma'am, it is visible now.
Yes, ma'am.
Ma'am, you can start.
Okay. So, good morning, everyone. Today, because of Dr. Saran Panisar sir has given me a platform to share some of my knowledge that I'm having in regards to neuroanatomy. So, thank you, sir, for giving me an opportunity to share some thoughts about this topic as such. So, quickly, let's start the topic without much delay. So, coming to the slide. Okay, the first slide is about the nervous tissue. So we'll start with the introduction itself. The topic I have chosen is the clinical aspects of neuroanatomy. So many things are there in this. It's a long list actually, but still as much as possible in 1 hour, let's take the overview of each slide. So I have taken the things in order right from the nervous tissue till the internal capsule. So we'll go in the same order so that there is continuity with the clinical aspects what we are dealing with as such. So to begin with, the nervous tissue slide. So first is what we study in the clinical neuroanatomy. So what is nervous tissue? What are the different neuroglial cells related with the nervous tissue as such? So we are going to talk only the clinical aspects. So what can we see in the neuroglial cells? There are different types of neuroglial cells in the slide. So we can see in the slide the ependymal cells. We can see the oligodendrocytes, satellite cells. So many cells are there. So in any of the cells, there can be the presence of tumor. Okay, so malignant or non-malignant tumors. So that is what we can call them as gliomas. So gliomas, neurogliomas. So they're highly malignant and they're rapidly growing tumors. So gliomas are the words then we get in accordance with the tumors related to the neuroglial cell axis. So in the slide there are diagrams showing you the different types of neuroglia or the neuroglial cells as such here. So after this, we will go to the next slide. So with the next topic, that is when we study after the nervous tissue, we study slide first, CSF and meninges is the topic. So in the CSF, cerebrospinal fluid, we have many things or many clinical aspects. So to list out a few, so we can obtain the CSF. So CSF, obtaining the CSF can be diagnostic as well as therapeutic as well. So how do we collect the CSF? We collect it either through the lumbar puncture or doing the cysternal puncture or by doing the ventricular punctures as such. But most commonly that is practically used or that is practically that is employed is lumbar puncture. So where we pass the needle in the interface between third and fourth lumbar spine. So I have put a diagram of the slide in that. So you can see a person, so how we do the lumbar puncture in lying position and even in the sitting position. So we do it between the third and the fourth lumbar spine. So that's how we do the lumbar puncture, and by doing this, we obtain the CSF, and then we send it for the biochemical analysis to see what has happened as such. So this is one important clinical aspect of this. Apart from this, I have given in a slide so the table. So this table talks about the pressure, how much should be the normal pressure, what should be, how much should be the protein value, how much should be the glucose value, etc. So these are the reference images that you will be seeing in the slide. So anything less or more than this will cause the respective pathology related to the CSF. So that is the purpose of sending for the biochemical analysis of the CSF to see whether there is a raise in the protein or less in the protein, to see whether there is increased glucose, so that we can conclude whether it is bacterial in origin or viral in origin, like that as such. So other than that, other common things we have is something known as lumbar epidural space. So lumbar is related with lumbar vertebrae. Epidural space is the space between the vertebral canal and the dura mater. So here also we can obtain the CSF as such. We can do the bricking and we can obtain the CSF also. Other than this, in this epidural space, we also give epidural anesthesia. So you all might be familiar with this name, epidural anesthesia. We also call it as painless anesthesia. Hardly there is any pain felt when the anesthesia is given in the epidural space. So nowadays, this is what is employed in the in spinal anesthesia instead of spinal anesthesia. Epidural anesthesia is what they're opting for maximum like that. So that's why I've written there this space is meant for giving anesthesia, or even analgesia is also employed in this case. Then we have very commonly that we see meningitis, which we call it as the inflammation of the pia mater and the arachnoid matter. So pia mater, arachnoid matter, they are known as the meninges of our brain. So they can be tubercular or they can be even pyogenic in origin. So meningitis is another common anomaly that we come across with regard to CSF. Then we have one more condition, we call it as papilloedema. So where we have when do a person go into papilloedema? If the CSF level is raised, if the CSF pressure is increased, then it will compress the retinal vein. It will compress the retinal vein, thereby it is going to lead to the swelling or the forward bulging of the optic disc. And clearly we can see this condition papilloedema by seeing through a ophthalmoscope. So basically is it countered is basically there is a rise in the CSF pressure. Because of that, there is dilation or there is compression to the retinal vein, leading to the condition known as papilloedema. Okay. After this, we are having some more things. Hydrocephalus. Commonly, you might have heard about the hydrocephalus, where there is a dilatation of the entire ventricular system. So we can have the hydrocephalus as communicating or even as non-communicating type. So communicating is external. External means outside. The obstruction is seen outside the ventricular system. So where do we see outside means? Usually we see it in the subarachnoid space. Okay. So when we see this kind of communicating hydrocephalus, we see the head is rather large in the size. The scalp veins, in the scalp region, the veins are enormously dilated in that region as such. Similarly, we have non-communicating hydrocephalus, which we call it as internal. Internal means this obstruction is going to be seen inside the ventricular system, and usually the cause will be a tumor or a inflammation in that ventricular system. So we can also do the shunt procedure to remove this non-communicating hydrocephalus condition as such. Okay. After this, so till here I have sorted out the clinical anatomy for CSF and meninges in brief like this. So these are the basic and most commonly common clinical aspects that we get in when we are sitting in our OPD as such. Fine. Next, I have gone for explaining about the spinal cord things as such. So in spinal cord also we have to take. So there are many things related with the spinal cord aspect also. So in this, we are going to get poliomyelitis as one condition. Poliomyelitis is one condition. We call it as LMN paralysis. Okay, LMN is lower motor neuron paralysis. So I think before that, I want to show you this table. The table is about UMN paralysis and LMN paralysis differences. So try to see any one. So any one you remember, the contrasting will be the other one. For example, if they are taking UMN, upper motor neuron paralysis, then what do we appreciate in this condition? Usually there is hypertonia. Hypertonia is increased muscle tone will be there, and as muscle tone will be increased, but as such there is no muscle wasting or muscle atrophy as such. That's why we call it as spastic paralysis in this condition. So once, and we find hyperreflexia, increased reflexes are there in this, and usually when there is injury to the UMN region, so extensive damage can be encountered, and they are contralateral. Contralateral means it is seen on the opposite side of the body. Ipsilateral means it is seen on the same side of the body. Okay, and Dabney sign is positive, whereas in LMN it is negative. That's why I'm saying just try to remember any one part so that you will be writing the opposite for the other part. So without knowing the basics of upper motor neuron and the lower motor neuron, the table, so you will not be able to understand the pathologies related with this. So I have jotted out two pathologies in this. One is poliomyelitis, another is stapes dorsalis. So poliomyelitis, we commonly know what it is, but I don't know how many of you know that this is LMN paralysis. So it's basically a condition where there is lower motor neuron paralysis as such, and it is viral in origin. Viral in origin. So what is affected here? Anterior horn cells which are present in the spinal cord, they are affected here. So how are they affected there? There is flaccid paralysis in this condition because it is LMN. So it is obviously going to lead into flaccid paralysis. So once there is poliomyelitis, what is affected then? There we see the affecting of the upper cervical segments. So C1, C2, C3, C4. So upper cervical segments are basically affected, and especially they say that if the C4 segment is involved, when involved in the injury as such, so then it may be fatal, because what happens, the same set of segments, C4 segment, will supply the diaphragm through the phrenic nerve. So which are diaphragm is again our respiratory muscle. So because of that injury to the diaphragm via the phrenic nerve, it may be known as fatal to one's life if C4 segment is especially harmed or injured in this case. Another common condition we have is tapes dorsalis. Tapes dorsalis. So this is the last end stage or the tertiary stage of the syphilis. So we are familiar with the syphilis also. So what will happen in this condition? There is severe pain in the lower limb because the injury or the site of occurrence of the lesion will be in the lower thoracic and lumbosacral segments. So these are basically the degenerative lesions that we are finding or encountering in the lower thoracic region or in the lumbosacral region. That is why the pain is seen in the lower limb as such. So where does this happen? Where does the lesion occur? So they occur in the dorsal nerve roots of the spinal cord as well as in the posterior white columns of the spinal cord. So I have taken important ones, so which we see in day-to-day life of this. Then I have also chosen conus medullaris syndrome. We have heard of this word as such, conus medullaris. So at the level of L2 vertebrae, so how many we have? L5, L1 to L5 is our lumbar vertebrae level. So in that L1 to L5, the lesions when we are seeing around the L2 level. So L2 level, we have the conus medullaris. So if the L2 level is affected, then we come across the syndrome known as conus medullaris syndrome as such. Okay, so then what do we see? So L2 means you can imagine it is lower back region, right? So we can see the onset of severe back pain in that case, perianal anesthesia, early bowel and bladder dysfunction, because that is the region of our hypogastrium even. So bowel and bladder are related very much in the L2 level. That's why we can see the injury even being caused to the bowel and the bladder region in when there is conus medullaris syndrome as such. Other than this, the most common one we have is cauda equina syndrome. So cauda equina also, as I discussed, like LMN and UMN, like lower motor and upper motor neuron. This is coming under the lower motor neuron paralysis. Only if there is lower motor neuron involvement, then we have come across the cauda equina. So this is also related with the lower limbs because again it is in the lumbar region as such. So where will the lesion be seen? It will be seen in the ventral nerve roots of the spinal cord. So all these things are coming in relation to the spinal cord clinical anatomy as such. Okay. So many things are there. So let us see which are majorly important and day to day what we see in our routine practice as such. Because if we going on listing, then there are many things that we are going to get in this. So next I have started with brainstem. I have gone in the same order like how we teach the students right from the nervous tissue. So I'm presenting in the same way so that there is good amount of connection between each and every passing structure as such. So next we have is the brainstem. So brainstem, when we say quickly, we get to know three things. One is the midbrain, another is the pons, another is the medulla oblongata, which is going to make the brainstem. So let's see now which are the things in medulla oblongata. First we see is medulla oblongata. So from the foramen magnum, so it will come out and continue as the medulla oblongata. So there we are having two kinds of major syndromes. One we call it as medial medullary syndrome, another we call it as lateral medullary syndrome. So medial medullary, the word itself will tell us that there is a lesion in the medial part of the medulla. So there is a diagram in the slide also. You can see the diagram there in the slide. So I have shown the TS of the medulla. So transverse section of the medulla, when we see, the diagram looks like this. So in this diagram, you can see the medial portion and the lateral portion that is involved. So when the lesion is seen in the medial portion of the medial part of the medulla, we call it as by that name medial medullary syndrome. So basically anterior spinal artery is affected in this because anterior spinal artery will be supplying the medulla oblongata. So obviously this will be affected. So then what all we can see the signs as such, we can see the contralateral hemiplegia. Contralateral means the paralysis is going to occur on the opposite side. If the paralysis is seen on only on one side, we call it as ipsilateral. Contralateral means when it is seen on the opposite side, we use the word as contralateral. So we encounter this contralateral hemiplegia when there is damage to one of the important structures of the medulla, which we call it as pyramid of the medulla. Okay, so it's there in the slide again. Other than this, we are going to have the person will have the loss of sensation of vibration in position, that is proprioception. So when it will happen, when there is injury to the medial lemniscus, and whatever of the words I have written here, medial lemniscus, corticospinal tract, hypoglossal nerve. So these are all the structures which are coming on the medial aspect of the medulla, in medial aspect of the medulla oblongata as such. Okay. Then there is also, they have said that hypoglossal nerve is also involved in this medial part. That is why if there is paralysis to the, if there is injury to the 12th cranial nerve, that is hypoglossal nerve, then there is paralysis of the tongue muscles. So basically we are having 4 intrinsic and 4 extrinsic muscles related with the tongue. So we are going to have see the paralysis of those tongue muscles because there is involvement of the hypoglossal nerve also in the medial part of the medulla as such. And next we are having is the lateral medullary syndrome. So again, let's go back to the slide once, diagram slide, and so what is there seen the slide there, lateral part, so that we call it as the lateral medullary syndrome. So in the lateral medullary syndrome, the main artery that will be supplying is the pica. Okay, pica, posterior inferior cerebellar artery. Okay, in the medial it was anterior cerebellar artery. In the posterior, in the lateral side, it will be pica. We call it as posterior inferior cerebellar artery. So this is infarcted. We can see the infarction in this artery. We can see the thrombosis in this region. So we also call it as pica syndrome also in this region. So we can encounter many things. They say that there is hiccups is what is the main thing in this lateral medullary syndrome. Hiccups, once it starts, it will not stop. Continuously intractable. So we can also use one more word that is intractable hiccups. So which is a cardinal feature in this. Other than this, there is dysphagia, that is difficulty in swallowing because pharyngeal and esophageal reflexes are not working very well. There is lack of coordination in these esophageal and pharyngeal sides of swallowing centers. So we can also encounter the dysphagia. Hyponatremia. Hyponatremia is a decreased sodium levels. So that is also going to be seen. So because there is something known as SIADH. So anti-diuretic hormone is going to get secreted in an inappropriate way. So because of that, the person can have lower sodium levels. We call it as hyponatremia. Other than that, we have ipsilateral loss of pain and temperature of the face. So why we see this condition? Because there is harm to the trigeminal nerve, which is our 5th cranial nerve. So whatever structures you are seeing in the slide diagram, lateral medullary syndrome, so whichever structures are coming there, so whichever structures will be affected in the lateral side, that respective symptoms we are going to call them as pathologies of that respective structures as such. Okay. Next, I have listed for pons. So in the pons, we are having 2 important things. One is spontaneous hemorrhage. I have highlighted in the slide that it is fatal. Okay, it is fatal. So why? Because spontaneous hemorrhage. So bilateral. So we see the involvement of 5, 6, 7, 8 cranial nerves in this, which are very important ones, and we see the incorporation of corticospinal fibers mainly in this pons region. So when there is a hemorrhage in this region, the person can go into deep coma also. Reticular formation will be disrupted. Once the reticular formation is disrupted, then the person will go into deep coma and that becomes fatal for him further. Other than that, so this is one important condition. You must know that spontaneous hemorrhage is fatal because there is bilateral paralysis of face and limbs here. Okay. Other than that, we have one more important condition. We call it as astrocytoma. Astrocytoma, the word itself is there. What is the reason for this condition? So a cytoma is basically a tumor. This is basically a malignant tumor which is occurring because of the astrocytes. So in the first beginning slides, I showed you the types of neuroglial cells, right? Astrocytes, ependymal cells, satellite cells, all these different types of glial cells. So among them, one is known as astrocytes. So astrocytes is basically going to make up a maximum portion of our human central nervous system. Okay, so when there is an injury to this or when the tumor is developed on this astrocyte, then we call the condition as astrocytoma. So basically the person will have fatigue and depression as the main symptoms. Fatigue and depression, and person will have repeated seizures. So seizures they describe in the way that as an episode in which the individual appears detached or staring. Either he will be totally staring at one person, like totally it will be like that, so staring, or he looks detached. So that's how they describe the mode or episode of the seizures here. Also, I have put a slide here in this fonts section just to show you this two slides. In one, I have put two diagrams. So in the one diagram, you can see astrocytoma, how the tumor will be seen in the CT scan. How do we see it in CT MRI scan? So there is one diagram above. Diagram is colored one diagram. Below that, we have put how the radio imaging will look. So in all the four diagrams, you can see there is a presence of tumor. So in different, where there is fonts, in that there is tumors, and tumor, in that tumor, which cells are involved? The cells involved are astrocytes. So you can see them looking translucent, right? So they are the ones radiological imaging we see when we do the MRI or CT scan. This is how it is going to appear. And one more slide is there. So only one diagram is there in that slide, in the font slide. So there also we can see the presence of huge tumor. Arrow mark is pointed out. The red arrow mark is pointing towards the tumor there. Okay, so that is also there, which is showing the presence of astrocytoma as such. Okay. Then last part of the brainstem, we call it as midbrain, right? So midbrain, we are having again many things. Important ones only I have listed here. So one we call it as Weber syndrome. One more we teach the students is Perinaut syndrome. Perinaut syndrome is, so midbrain means immediately we remember three things. One we remember is red nucleus. Another we remember is superior and inferior colliculi, right? So one is doing the auditory function, another is doing the visual function, isn't it? So we remember these things. And basically in Perinaut syndrome, there is a lesion in the superior colliculus. So once there is a lesion in the superior colliculus, then it will harm our visual vision. So there is weakness of the upward gaze and the vertical nystagmus. Nystagmus is basically the involuntary movement of our eyeballs. Okay. So from side to side, involuntarily, without our knowledge, there is movement of lateral movement of our eyeballs. So vertical means up and down movement of the eyeballs without our present knowledge. So involuntary, there is movement of our eyeballs, which we call it as vertical nystagmus. So that is one condition. And Benedict syndrome is totally the tegmentum will be damaged. So we have two things in midbrain. One is tectum and another is tegmentum. So among the two, the tegmentum will be damaged too much. So mostly the segmental damage is seen in the Benedict syndrome, and as a result, the person will have loss of proprioception, and there is tremors that is felt continuously, and twitching is there on the opposite side. So when we see opposite side, so then we have to tell it as contralateral. Okay, red nucleus is also affected there. Other than that, we are having Weber syndrome. So in the Weber syndrome, basically there is involvement of oculomotor nerve nucleus. Oculomotor nucleus nerve is our third cranial nerve. So that is involved in Weber syndrome, and because it is involved, it will lead to contralateral hemiplegia. That is the opposite side paralysis is seen, and our pupils will be directed downwards and laterally. Pupils will be directed downwards. Pupils will be looking downwards, and they will also be seen on the sides laterally because there is paralysis towards oculomotor nerve. So these are the three important syndromes that we list when we talk about the midbrain as such. Okay. So with this, we come to an end of this brainstem anomalies, means regularly what we are going to orient students as such. Next we have is cerebellum. So same order it is again. So in the cerebellum, we call it as the little brain, isn't it? We call it as the little brain. Cerebrum is our major, 90% of the brain is cerebrum, and younger brother or younger brother of that, we call it as the cerebellum. Cerebellum, we can list many things in this. So I have listed few things which are important ones. So basically, any things we use the word there as cerebellar dysfunction. Cerebellar dysfunction. So in that, basically we see the lesions to the vermis. So if you see this diagram related to the cerebellum, if you remember this diagram, so there are 10 divisions, subdivisions of the cerebellum. The first one we call it as the vermis. Vermis is basically related to the emotional control also in us. Then lobe-wise, we are having three lobes: anterior lobe, posterior lobe, and the middle lobe. Okay, fissures, we are having three fissures: primary, horizontal, and the posterior. Vermis is the region which is, if it is affected, or if there are lesions in the vermis region, then there is truncal ataxia. Okay, ataxia is the gait of the person will be improper. Okay, and basically vermis, as I said, it is also related to emotions. Other than that, there is also nystagmus in the heading of cerebellar dysfunction as such. Other than that, is there is lobe to the anterior lesion. Anterior lobe, three lobes are there related to the cerebellum. If there is lesion in the anterior lobe, then there is condition known as gait ataxia. Gait ataxia, so the person will be walking like an alcoholic person. So we call it as staggering gait. The person will not be able to walk in a straight line. So like an alcoholic, he will be walking. So there they, why it happens? It happens if there is a lesion in the anterior lobe of the cerebellum. Other than that, we are having cerebellum cognitive affective syndrome. So this syndrome we are going to see when there is thrombosis in any one of the arteries. So basic arteries related to the cerebellum are, I have given in the note there. Okay, one is superior cerebellar artery, another is ICA, another is PICA. Three arteries are there, but they are on two cerebral hemispheres, so that the number comes to six there. So any one of these arteries occluded, or there is thrombosis to any one of these arteries, then we can come across this name known as cerebellum cognitive affective syndrome. So when the syndrome is there, then the person will not have the attention to details. He will not have attention to details. Then lot of grammatical errors are there in the speech. When he's talking, there are too many grammatical errors, and there is patchy amount of memory loss. So sometimes he's able to recollect something, and sometimes he's not able to recollect the past events. So we call it as patchy memory loss. So these are the things we have in cerebellar dysfunction. Next, we have, after the cerebellum, we are having is the fourth ventricle. So in the fourth ventricle, basically, we call it as one of the important among the four ventricles of the brain. This is one they have as important for clinical aspect, because we have the vital centers. Vital centers are the respiratory center and the cerebrovascular, cardiovascular centers are related with the fourth ventricle. So these are seen in the floor of the fourth ventricle. So it is there in the diagram once again. It is there in the diagram once again. So any injury to these vital centers, respiratory center or cardiovascular centers, will turn fatal to one's life. So other than that, we are going to see the increased intracranial pressure if there are tumors in the region of the foramina. So foramina is related with this fourth ventricle. One is foramina of Lashka and another is foramina of Megendie. So it is there in the diagram once again in the slide. So if there is any tumor related to this, then it will cause a raise in the intracranial pressure, as a result of which person will have severe headache, vomiting, and papilloedema. So these are the two things which we see. Mainly you have to remember is vital centers. If they're injured, then it will turn fatal. And if we know that hanging, the death during the hanging is going to occur, so because of the because there is transverse ligament of the atlas is going to sit with the dens, so they are articulated with each other. So when a person is going to hang himself, then the dens is going to become free. Once the dens is becoming free, then it will hit backwards on the vital centers. So on the back of the dens, there is floor of the fourth ventricle, and on the floor of the fourth ventricle, we are having the vital centers. So once it is hit there, then immediately the person will die. So that is the reason why there is death, immediate death after a person hangs himself. So this clinical aspect also is related with fourth ventricle. Then we have gone into the cerebrum, details of the cerebrum. So cerebrum also is very huge. So many things are there to speak in the cerebrum. But I've taken two examples from two examples from functional areas, two examples from degenerative changes. What are the things that we see when there are degenerative changes like that? Only few I have taken just to give you an example, like how we have to study it. So for example, if we see the areas 312. We call the area 312 as general sensory area. So if there is injury to these general sensory areas, then there is loss of fine movements. So it may be the sensations. Sensations will be lost, fine touch, fine movements, fine position of the part of the body. All these sensational loss, discriminative sensations will be lost in the person. Similarly, area number 5 and 7, we call it as superior parietal lobule, this area. If there is a lesion in these areas, area 5 and 7, then the person will have two conditions. One, we call it as tactile agnosia. One condition is tactile agnosia, where the person will have the inability to recognize objects by hand. So anything, any object is having in the hand, he can recognize it by the sight. He can name the objects by sight, but by hand he cannot recognize the object. So we call it as tactile agnosia. Similarly, there is one more thing known as astereognosis. Astereognosis is further one step ahead of tactile agnosia, where the person will not be able to discriminate the shape, size, and contour by touch. So when you give a ball in his hand, so he cannot understand what is the shape of that, how big is the ball, and how is the contour of the ball. He cannot tell these specifications to you. You cannot expect that to happen. So that condition we call it as astereognosis. Similarly, primary visual area is area number 17. So if there is injury to this area or lesion in this area, then the vision loss is there in the visual field of the opposite side. Okay, so right-sided vision, right side there is a lesion, so the effect will be seen on the left side. So that's why the word used there is opposite side. Similarly, we have so these are some of the things which we have listed for under the section of functional areas of the brain. So again, as I said, there are many things. If we list, it will go up to even 45, 50 also. Okay, next I've listed two more things, common things. We call it as dementia and Alzheimer's disease. So dementia, we know about that. So slowly and progressively there is loss of memory, intelligence, and our personality. And the reason for this dementia is basically the Alzheimer's disease. So I've shown in the diagram here in the slide. So how is the normal brain versus how is the disease with the dementia as well as the Alzheimer's disease. So you can see here, day by day degenerate as there is aging of the brain. Okay, as there is aging of the brain in the dementia or the Alzheimer's disease. So in the hippocampus region, I've shown in the slide, there is too much of shrinkage in the hippocampus. The ventricles are increased in size, severely they are enlarged. And similarly, there is atrophy of our cerebral cortex. So it is totally contrasting to our normal human brain. So we call it as Alzheimer's disease. Next, we are having something known as diencephalon. Under the section of diencephalon, we are going to get some important things, structures like thalamus, hypothalamus, like that. So first we will see about the thalamus. Again, in the diagram, I can show you the thalamus. So you can see the location of the thalamus. Again, the ovoid masses of the gray matter is situated in the diencephalon cavity, in the cavity of lateral ventricle, just below the lateral ventricle. Okay, we have an important syndrome related to this. We call it as thalamic syndrome. Thalamic syndrome. So when we use the syndrome there, so we have a list of many symptoms there. So that is when we use the word there as syndrome. For example, mainly in this thalamic syndrome, there is injury to the PCA, posterior cerebral artery, is one of the chief arteries which is supplying the thalamus. So because of this, there is injury to this thalamus. And there can be burning sensation, tingling pain, loss of sensation of temperature, because basically we call this thalamus as the relay station. So whatever impulses will come from the different regions of the body have to come to the relay in the thalamus first. So only later the sensory information will be conveyed to the respective areas of the cerebral cortex. So we call it a sensory relay station as such. Okay. So these are the set of symptoms what I have listed. So pertaining to the thalamic syndrome as such. Okay, and there can be bleeding also in the thalamic region. We call them as microbleeds. So small vessels, if they're having the lesions, so we call them as microbleeds. Large lesions are there in the thalamic region, so we call them as large thalamic bleeds as such. So hemorrhages, basically there are hemorrhages. If the injury is to the small vessel, then there are microbleeds. If it is for a larger vessel or larger area in the thalamus, then we call it as large thalamic bleeds as such. Okay. Then we have glioblastoma, so which is also related with the thalamus. In the earlier slides, when we talked about the neuroglial cells, so there also we had the word as gliomas. Okay, so here also we are having the glioblastoma multiforme, which is a giant tumor, a malignant tumor seen in the thalamus region. Okay, sometimes we can also see the hemorrhage in this region. Inside the tumor, we can also see the hemorrhage as such. One more tumor we can see in the thalamus is commonly seen is lymphoma. Okay, so these are some 3-4 important clinical anatomy related with thalamus structure. Next we have is hypothalamus. So in the hypothalamus also we are having different set of tumors, vascular tumors, CNS tumors, systemic tumors, etc. like this. So majorly what will happen with this thalamus injury? So first and foremost the person will have diabetes insipidus. Okay, diabetes insipidus, where there's excretion of large quantity of water through the urine. Okay, we call it as, so as a result of this, person will have excessive thirst. That we call it as polydipsia. And there is supraoptic nerve damage in this region, diabetes insipidus. Okay. Other than that, we are having many hormonal anomalies in this region. Okay, dystrophy, adipogenitalis, Kallman syndrome. So I've given in the slides all these things. So many hormonal disorders we can see in this. Other than that, we can see narcolepsy. Narcolepsy is related with hypothalamus. So pattern of sleep is totally abnormal. So hardly he sleeps for a very short duration, so few seconds to 20 minutes. At night, he will have disturbed sleep or he will have insomnia. And suddenly he will have an attack of uncontrollable desire for sleep. Suddenly the person will fall asleep. Suddenly he will wake up, and this episode is seen more in the daytime than in the nighttime. We call it as narcolepsy. Similarly, we have one more condition known as cataplexy. Cataplexy, where there is uncontrolled outbursts of emotion. So this is also, we can say, very much related with or associated with narcolepsy itself. So there he will have attack of uncontrollable sleep desire. Here he will have uncontrolled outbursts of emotion. Okay, totally, because as a result of total muscular weakness here. So this attack also can last from few seconds to few minutes. But one thing you have to remember in this, the consciousness of the person will be normal. The consciousness will not be lost. Only the things what comes out, the outbursts of emotions, what will be there, that will be involuntary in nature. Okay. Next we have is corpus callosum. So there are again many things to say in corpus callosum. So one important thing we have is agenesis. Agenesis is totally, there is no corpus callosum from the birth, or there is partial or complete absence of corpus callosum in the region. So because of that, there will be a wide range of change in the physical and the behavioral patterns of the person, symptoms of the person. So this is known as agenesis. So either there is partial or there is complete absence of corpus callosum. So basically, this corpus callosum is a commissure fiber, largest commissure fibers in the white matter of the brain. So in the diagram, shown the diagram in the corpus callosum, having the different parts, rostrum, geno, body, stomach, splenium. So these are different parts related with the corpus callosum as such. Then we are also having impingement syndrome, corpus callosum impingement syndrome. And when the person is having long-standing hydrocephalus, then there is ischemia in this region. Ischemia is inadequate supply of the blood. So because of this, there is atrophy to the corpus callosum, and that's what, there's atrophy and there is ischemia in this region. So we call that condition as impingement syndrome, corpus callosum impingement syndrome. Usually it will be seen as incident finding because there are no symptoms in this case as such. Okay. Then there is something known as disconnection, split brain syndrome. So what is the basic work of this corpus callosum is transmission of the impulses to the opposite hemisphere. That means the conduction of the fibers should be from right cerebral hemisphere to the left cerebral hemisphere and vice versa. It should happen like that. But sometimes it cannot happen. In case something that is known as split brain syndrome, when there is split brain syndrome, so there is no transmission of the information of the fiber from one end of the hemisphere to the other end of the hemisphere. Okay, so for example, if you're writing your name with a letter, if you're writing your name in the right hand, so we can do that. Suppose we are right-handed people, we can write our name with our right hand. same name, if you are asked to write with your left hand, then you will be able to do that work. Still we can write our name with our left hand. So this is possible only because of the transmission of the fibers from right cerebral hemisphere to the left and left to the right cerebral hemisphere. So this will not be seen in the split brain syndrome as such. So because there is a loss of fibers only will not be sent to the opposite cerebral hemisphere. That's why it becomes non-functional. The other cerebral hemisphere will become non-functional. There is no transmission of the impulses, and because of that, so you cannot write your name in the left hand, so like how normally we do in that case. So that's where we call it as split brain syndrome, or we call it as disconnection syndrome. And lastly, we are having is internal capsule. So internal capsule studied under the heading of projection fibers. So they are again coming under the white matter of cerebrum. So these are the fibers, sensory fibers, where the fibers are going to relay from the cerebral cortex to the other structures of the CNS, and even outside the CNS till the level of spinal cord, and vice versa. So that's when to and fro, centripetal fibers, centrifugal fibers. That is how we have. Some will relay from the cerebral cortex, some will relay towards the cerebral cortex. So this is one example, important, very good example, where we call it as internal capsule. One of the best examples for projection fibers. So in this projection fibers, internal capsule, first I have shown one diagram here. So in this, first you have to remember the parts of the internal capsule. One is anterior limb, genio, posterior limb, sublentiform part, that is below the lentiform nucleus. There is a part of the internal capsule, we call it a sublentiform, and behind the lentiform there is a portion of the internal capsule, we call it as retrolentiform. So these are the 5 regions. So the lesions can happen in any of the 5 regions. First thing. Second thing, blood supply is different for different parts of the internal capsule. Different blood, for example, anterior limb means there is anterior cerebral artery for this. Okay. So like that, there are different blood supplies related with the different parts of the internal capsule. Wherever there is a thrombosis, that respective pathology we will see in the internal capsule. So this basic idea you should have before we go into the internal capsule clinical part. So for example, I have listed some of them here. So we have something known as lacunar strokes. So ischemic, because of the inadequate supply of blood to any of the particular area of the internal capsule, we can see the blockage of the perforating arteries. So we call it as lacunar strokes. Lacunar strokes, which is one of the type of cerebrovascular accidents. So in this kind, they find the contralateral hemiplegia and equilateral human type of facial palsy. Similarly, another most common site for lacunar stroke is the posterior limb of the internal capsule. Posterior limb of the internal capsule is more prone for stroke. Okay, more prone for strokes because it is supplied by different artery. We call it as middle cerebellar artery. Okay. Then we also have clumsy hand dysarthria. So where there is difficulty in the articulating speech, clumsy hand, the person will not be able to write clearly because there is weakness in the hand, because there is lesion in the anterior limb of the internal capsule. Because of that, dysarthria means we will lose the articulation of speech, and clumsy hand means because of the weakness, muscular weakness in the hand, we will lose the grip of writing. So we call it as clumsy hand dysarthria. So these are some of the things which we have under the heading of internal capsule. Other than that, we have here some of the things just have given. For example, so like I told, anterior limb, there is different pathology. If there is lesion in the anterior limb, so there can be confusion, impaired attention, agitation, dysarthria. If there is lesion in the genio region, so then there is the involved structures are the face and the tongue, weakness in the face, facial muscles, and the tongue muscles, in addition to dysarthria. So like this, we can see different types of pathologies in different parts of the internal capsule as such. For example, sublenticular part, sublentiform below the lentiform nucleus. When there is lesion in the internal capsule, the person can have auditory deficit, hearing loss will be there, or hearing deficits will be there in that region. So like this, these are the list of deformities which we can see in relation to the internal capsule. So this was the overview of this clinical aspect from page 1 to the last page ending with internal capsule. Thank you for your cooperation and time. So you have any queries, any questions, we can have a discussion on that.
Thank you so much, ma'am, for the brainstorming session. I think many students will be benefited from this class. And of course, all the participants, I will request you to put your questions and doubts in the chat box, so which we can be discussing in the question and answer session. So, ma'am, we will wait for just 2 minutes. If anybody has some queries, then they can put in the chat box. Yes, all the participants, if anyone has any queries, then you can put in the chat box. So we will discuss with our guest speaker. Yes, ma'am, we have received some questions.
Yes, ma'am.
So, ma'am, first question is from Dr. Praveen Kumar. He's asking, ma'am, narcolepsy and cataplexy is more serious or not? If serious, how to treat? Narcolepsy and cataplexy.
As per the treatment, we are not discussing that part as such, but yes, they are serious, more serious conditions because they are involuntary in nature. So certainly they are more serious because there are sudden episodic attacks in that region. Both
So,
of them.
dear participants, I will request you all that we will be discussing the anatomical aspect of all the things. So, treatment aspect we are not discussing today. Please put questions accordingly. So, ma'am, we have one more question. Ma'am, lacunar infarct and ischemic territory infarct. Treatment is same or different? Again, they are asking about the treatment. If you can give some views. Lacunar infarct is blockage of arteries. So, they want to
One
ask.
more is?
Lacunar infarct and ischemic territory infarct. So, it is different or same thing?
Different in the sense the cause is ischemia, that is inadequate blood supply is there because of the inadequate supply of the blood wherever is the inadequate supply. For example, if the inadequate supply is in the anterior limb, if it is in the genu, so in that region there is ischemia. Because of that, as a predisposed factor, we can see something known as lacunar strokes in that area, or there is occlusion or there is rupture of these vessels, whichever arteries are supplying in that region. So that particular artery will get occluded or it will get ruptured. So those we call them as ischemic strokes as such. So they're secondary to the blockage. And that secondary thing, we call it as lacunar strokes. So lacunar strokes are not very superficial. So these are basically going to affect the deeper structures of the brain. So for example, basal ganglia. In the basal ganglia, we are having the putamen, we are having caudate nucleus, thalamus, central capsule. So all these things are going to be affected by the lacunar strokes. They won't be affecting the superficial structures in the brain. They are going to affect the deeper structures in the brain.
So, if any other question is there, someone is asking about meningitis. Ma'am, If you can explain something about meningitis.
That is the only one question.
He's actually
Basically,
asking about the treatment of meningitis by the help of Ayurveda. So,
treatment as
treatment,
such, I don't think we can manage with ours in that, to be frank. So symptomatically we can drink because it is involved with the meninges, pyomatter and arachnoid meninges, and usually they are tubercular or pyogenic in origin. So I don't think we can even treat that with our medications because it is affecting the meninges. So symptomatically also it won't work well with ours
yes,
because there is
I
change in
also
the
think, ma'am, in acute cases, actually, it is very difficult to manage through Ayurveda. But when patient come in later stages, like after 6 months or 7 months, many patients are coming to our hospitals also. So there we can recover the, like if paralysis is there, plagia is there, so we can recover it
that's
by
what ma'am.
panchakarma and
Secondary
all.
forms of that we can, as a symptomatic relief we can, but still we cannot have the promising results with our medications in this case because already the meninges have been inflamed or interrupted to a greater extent, and we fever it will be persisting, it will be recurrent, headache will be recurrent, it will be persisting, neck rigidity will be there. So they are all more of structural things. And CSF, there are a lot of biochemical chemistry analysis of the CSF when we are doing. There are a lot of changes in the biochemistry of the CSF also. So not very easy, or not, we cannot assure much to the patient as such is what I feel.
Yes, ma'am. One more question is there from Datta Prasad Pawar. He is asking to explain the types of meningitis. If you can provide some
Types,
information on the
one is tubercular. If it is tubercular origin, we call it as tubercular, or as pyogenic. They are the types.
tubercular and pyogenic. So these are the types of meningitis. I hope he has received his answer. So any other questions from our participants? I think there is no other question, ma'am.
Yes, ma'am.
So
Thank you
I
so
will
much, ma'am.
invite our sir, professor from anatomy, Sri Rachna department for vote of thanks.
Once again, good morning to all. First of all, I wish to thank our Honorable Chairman, Sharon sir, and the Chairperson, Ma'am Sunita ji, and our Principal, Dr. Surendra Kumar Bishwal ji. I am giving heartfelt thanks to these people. And the main and the most important person of today, the guest speaker, Dr. Dipti. You have presented a highly informative and the systematic neuroanatomy along with the clinical aspect of it. And I am very proud of you. Why? Because you are the learner from me, the dissection.
Yes, sir. Yes, sir.
Okay. That's why I wish to thank more and more. And I wish you all the best in future. And again, I will thank my technical team, the lovely couple, Dr. Sahu, Pritimai Sahu and the Niranjan, Rihar Ranjan Mohanta. Both are very intelligent and technical personalities in our interest. I'll heartful thanks to them. And one more person who is behind this program, that is Dr. Shinaz. I'm giving more and more thanks to him. And not least, but the most ultimate personality is the audience of this program. I am giving sincere thanks to all of you. Thank you very much. Thank you very much. Thank you very much.
Thank you so much, sir, for all the appreciation. And with this, we end the Parva 13, episode 13 of today's webinar series, Prabodhini. And I really heartful thank to our guest speaker, Dr. Dipti Godbole, ma'am. She was really stunning and very nicely she presented all the things, all the concept of neuroanatomy and skillful aspects. So
Thank you, ma'am.
with
Thank
this,
you.
thank you so much, ma'am. We will look forward in future also for many more sessions from you. So please be with us, always support us like this only.
Sure, ma'am. Sure. Anytime. Thank you so much for spending your time for this and giving me a platform to share some knowledge, whatever I have. And special thanks to Han. Sir was HOD when I was working in a earlier college, inside college. So sir has given me a time today to come out with some thoughts that I have with me. Thank you once again, Sir Parents and Sir.
Thank you so much, ma'am. Thank you to all the participants. So we will end this session with our national anthem.
Sure.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much, Vande Mataram all, and you all will be receiving your certificates within 7 working days, but attendance is compulsory. So we will look into the system. Those people who have more than 45 minutes attendance will get their certificates. So thank you so much. With this, we end our session. And please be with us in the WhatsApp group because next proceedings we will be sharing in the WhatsApp group, Prabodhini. So thank you so much and namaskaram to all.